In addition to atropine and dopamine, we can also consider the use of epinephrine to treat symptomatic bradycardia. Epinephrine is a catecholamine. In this case, it would be an exogenous synthetic catecholamine. But we term this as a sympathomimetic, meaning that it mimics the effects of the sympathetic nervous system. So epinephrine has a higher affinity to what? Fill in that blank for me. Is it alpha or beta receptors? Epinephrine. And time's up. Has a higher affinity to beta receptors than alpha receptors. Okay? So that means that when we give epinephrine, its primary effect is going to be on beta receptors. So then, beta receptors, what are we thinking about? We're thinking of positive chronotropy and positive inotropy. So the key here to really understanding vasopressors is understanding their primary function and how they work in the body. And the reason for that is if I have a patient that's in distributive shock and their vessels are big and dilated, distributive widespread vasodilation, like neurogenic shock or septic shock or anaphylactic shock, then epinephrine, with the exception of anaphylactic, a little bit different story there. In general, epinephrine is not going to be the best choice of drug for that patient as a vasopressor goes, because we're not treating the underlying issue, right? If the problem and the reason the patient's blood pressure is low and that they're altered and so on and so forth is that their vessels are huge and dilated, then why is increasing the heart rate and squeezing the heart more efficiently going to help them? It will to an extent, don't get me wrong. But would it not be better to give a medicine that specifically acted on those vessels and helped to squeeze the vessels back to where they're supposed to be? Yeah. Excuse me. So think about that when you're choosing which vasopressor agent to use. Epinephrine works really good for bradycardia, symptomatic bradycardia. And the reason for that is because its primary effect, we'll put a number 1, or here's a first, and a second. That's not a 2. This is a 2. Its primary effect is on the heart rate. Epinephrine is really good at increasing the heart rate in most situations. It's also pretty good at squeezing the heart more efficiently. I'm sorry, excuse me. And it does squeeze the vessels, but that's not what it does really well at this dose. The cool thing about epinephrine is that the higher dose we get to, the more vasoconstriction we have. And the reason for that is because even though the affinity to beta receptors is higher than its affinity to alpha receptors, when I increase the concentration of epinephrine in the bloodstream, then I'm also going to increase the likelihood that epinephrine is going to bind to an alpha receptor. So therefore I increase the affinity. Excuse me. So I increase the concentration, I increase the affinity. My dose of epinephrine for treating symptomatic bradycardia per your state protocol is 2 to 10 micrograms per minute. This is not a weight-based drug. 2 to 10 micrograms per minute. And this should be given as 1 to 100,000 concentration. 1 to 100,000 concentration. That is epinephrine.